India. So I'm going to give brief introduction about them. The first expert is Professor Michael Goldberg. He is a chairman and professor of pediatric orthopedic at Seattle Children's Hospital. He is expert in the skeletal dysplasia, and he was a director of skeletal dysplasia department over there. There are many syndrome and the skeletal dysplasia named on him, his name. He is also famous for outcome measure analysis, like what treatment which we are offering to patient, and he was a pioneer person for that evaluation. He was a past president of POSNA, Pediatric Orthopedic Society of North America. At present, he is resident in scholar at SWAR Center for Compassionate Healthcare, which is a center which is trying to propagate the compassionate care by the doctors. His main focus at present is well-being of physicians and the physicians team. We have an expert from India, that's Dr. K Sriram. I'm sure that everyone knows Professor Sriram. He was a past president of Pediatric Orthopedic Society. At the age of 82, he is in active practice. And his major forte is like tuberculous spine and the skeletal dysplasia. The honesty, hard work, and humility are his hallmark. The most important thing which I always appreciate and we all should learn from is the learning is a lifelong process. Even at the age of 82, he listens to almost every webinar and then sends his comment and feedback. So that's one important quality which we all should appreciate and adopt. The another expert is Professor Benjamin Joseph, the founder member and again past president of POSI. He was head of the Pediatric Orthopedic Services at Kasturba Medical College, Manipal. He has authored 2 popular books, The Decision Making in Pediatric Orthopedic and about making a diagnosis. His major interest at present is, even after retirement, is like art and the pediatric orthopedic, and his 4 articles which published only last month in Journal of Pediatric Orthopedic about the art and pediatric orthopedic. I recommend all of you to see that article, and his thinking is always outside the box. The another 2 important quality is like he's a self-disciplined person and service about the self, and we all have adopted that quality from him. The 2 young experts from USA are Jennifer Wooze. She's a lead of pediatric orthopedic at Kaiser Permanente at South California. Is a board of director at American Academy of Orthopedic Surgeons. And at present, she is a chair of communication committee of American Academy. The physicians wellness and women in medicine and orthopedics, these are again her special focus. The expert is Cordelia Carter. She did her training from Yale Medical School, Boston Children's Hospital, and Children's Hospital of Los Angeles. At present, she is associate professor at New York University School of Medicine. Again, she is a director of Center for Young Athletes. She is also a chairman of POSNA's Wellness Committee. In addition to orthopedics, he has a keen interest in sports, and she is an active player and coach in various sports activities. Before I introduce you about the topic, I just request that this year we have, means in 2021, we have a virtual POSICON Pediatric Orthopedic Society Annual Conference. If you have not registered, please visit our website www.posi.in and you will be able to register from there. Now the most important question, a lot of colleagues ask that why this webinar? And I will just give you a brief introduction about why we are going to have this unique and thinking outside the box webinar. Most of the medical associations have activities like POSI. We try to share our knowledge, we try to train, we develop our skills, we carry out research activities, we try to develop white papers, guidelines, protocols, and at the same time we want to increase awareness amongst our patients and the family members. The aim of our society or all of this activity is a primary prevention of the disease. We also want to improve the results of our treatment. We want to avoid complications so that the treatment becomes more safe. And we always try to reduce the expense with the treatment, so almost everyone can afford the treatment. These are our aims. However, what we call it a patient-centric treatment, that's really good. We don't have any argument about that. But the problem is, while focusing all this, we forget about the wellness of doctors. And why I say like that, the recent statistics that say that the study which was published recently in Journal of Pediatric Orthopaedic, almost 38% of the pediatric orthopedic surgeons, they say that they are suffering from active burnout. This is really shocking. The person with a too much qualification or extreme qualification, intelligence, still they are suffering from burnout. And the another thing, amongst all professionals, the medical practitioner have a highest suicide rate. This is really surprising and shocking also. And why it affects and how it affects the treatment. When doctor is not in a good mental health, the poor mental health leads to poor decision. That results into more complications during treatment. That again results into a poor result. And that leads to dissatisfaction to the surgeon as well as to the patient. And that again adds on to the poor mental health. So this is a vicious cycle. And we have to break that cycle at some point. So this webinar is a first step. We accept that it's a small step, but at the same time, we are confident that it's going to have a huge impact and it's going to change the scenario in the years to come. Before we start the seminar, the format of this webinar is different. It's not going to be a didactic lecture, but it's in the form of questions and answers. We have selected around 14 questions, which is spanning across the topic, and we have experts, so they are going to give their views about the questions. In addition to that, if you want to ask questions, please feel free to WhatsApp your question on 98230-63989. So you can WhatsApp the question. At the end of the seminar, we will also take audience question. So with this, I start with the first question. I will end my presentation over here. And the first question, we would like to start asking the expert. And basically, we are talking about the physician's wellness or the doctor's wellness. This is extreme of what we call it a burnout. So we would like to understand in a simple term, what is physician's wellness? What do we understand by that? And what is the burnout, which is a very popular term nowadays? So I invite Cordelia to start the ball rolling. So please.
Fantastic. Thank you so much for that lovely introduction. And I'm so honored to join this panel. This is one of those times where I recognize that I'm really standing on the shoulders of giants. So, so thank you so very much for inviting me to be a part of this. I think the first thing I was going to comment or say in terms of comment was that burnout existed even prior to the current COVID-19 pandemic. And I think that as we continue, to work in this space, I think we're going to see both quantitative and qualitative changes in how we think about physician burnout, as a result of this. But so I think a lot of what we'll talk about is, burnout as we conceptualized it sort of prior to 2020. But I think that this will be an iterative process. But in short, burnout is a mental state that's characterized by emotional exhaustion, by depersonalization, by a diminished sense of personal accomplishment. In fact, it is now a medical diagnosis. This was made true in 2019 when the WHO classified burnout syndrome as a medical diagnosis. This was entered into the ICD-11. So this new diagnosis is defined or conceptualized as a syndrome of burnout resulting from chronic, ongoing workplace stress that has not been successfully managed. It is typically characterized by feelings of energy depletion or exhaustion, by increased mental distance from one's job, feelings of negativism or cynicism, and reduced professional efficacy. And one of the comments I wanted to make, and I will welcome anybody to jump in, please, was in that very first sentence that workplace stress over time is not being successfully managed. I find that term problematic in itself, because to me, it seems to connote personal weakness or individual inadequacy, a lack of resilience, which is something we talk about a lot, is how to build resilience. But when I hear those words, to me, that it almost seems to be finding fault or laying blame with the affected individual rather than with the context or the culture or the environment. In terms of, and you've mentioned some of this already, in terms of burnout, it is an epidemic in medicine amongst doctors and physicians and surgeons, and at least here in the US, up to 42 physicians do self-report burnout. This is 2 times the rate of US workers in other fields. We know that amongst orthopedic surgeons in general, the rate is about 34%. Among pediatricians, it's 41%. And then, as you also mentioned, we did a study among POSNA members and found that 38% of POSNA members reported feeling personal burnout, and almost half reported that they had members of their teams in the workplace setting that experienced burnout. And this is bad. Physician burnout is bad for our patients. It is associated with an increase in medical errors. This in turn may lead to more burnout, and so it can become a cyclical process. It's associated with poor clinical outcomes in patients and decreased patient satisfaction. But in addition to being bad for our patients, it's bad for ourselves. Physicians who are burnout experience higher rates of job dissatisfaction. And then also, as you mentioned, it may be a precursor to depression and suicide. And so, actually, I think I will end with there. Is basically, I've described burnout. We know it affects a significant minority of pediatric orthopedic surgeons, at least in the U.S. And we know that burnout is bad. So it's something that we have to talk about and understand so that we can, together try to mitigate its truly negative effects. And with that, I'll turn it back to you.
Okay, thank you, Cordelia. Now I would like to ask Professor Benjamin, do you think that in India we see such features amongst our colleagues?
I presume that it is there, but I think it is to a lesser degree. One of the reasons possibly is that a lot of Indians believe that the lot that they have is their fate, and they accept it as that, right? I, for one, it's an absolutely personal view. I believe in God. And I believe that the job that I have had is a gift, and I'm a steward. So I don't complain whether I got enough salary or whether my room was comfortable, whether my working hours were good or bad. I take it as what is given to me. And I think that if you have a theistic belief, I believe that some of these things can be a little minimized. And then you're not looking to compete with someone else. You're willing to do it just because it's an opportunity for you to fulfill something. And there's immense satisfaction. I can only say that if I look back at life and look at what has played out, the areas of stress, the worries that I had, I would, if I had to relive my life, I'd go exactly the same way, which probably means that it was an effective way to work. I'll stop with that.
Okay, yeah, but that could be your mindset, because like your mindset is very different than most of the young surgeons. That's my perception. I may be completely wrong. But let's have an opinion of Professor Sriram. Do you think that this problem is common in India? Like it's reported that 38% of the pediatric orthopedic surgeons, they develop this problem, or they have accepted that they are having this problem. Do you think that this is a common situation in India?
I can't comment as far as the pediatric orthopedic surgeons are concerned, but my search of the Indian literature on the subject of burnout, I could locate only 3 key articles. That includes the medical practitioners of all specialties that they have studied. For example, 300 resident doctors working in public hospitals in and around Mumbai were surveyed with a questionnaire. And they found out that 56.66% of the doctors expressed a burnout at some point of time. And 16.6% revealed client-related burnout. And they felt that the major barriers to their health were the stigma attached to the condition, lack of confidentiality. Another big study came up from the Postgraduate Institute of Medical Education and Research in Punjab, where they had sent questionnaire to 1,721 doctors, and 445 doctors responded with a response rate of 27.29%. 376 were resident doctors and 65 were the faculties. And it was very surprising that in a major academic institution like that, 90% of the respondents said they experienced burnout at some point in their academic career. And there was a much higher percentage among the resident doctors. Then there was an article in the Psychiatry, Journal of Psychiatry, where 482 medical professionals were analyzed. They were belonging to all branches of medicine. And they used the Maslach burnout inventory. And they came up with a figure of 45.02%. And like the Western literature, there was higher prevalence in the females, higher prevalence among older people with experience, and among the academicians. So we don't really have the breakdown data either for surgeons or physicians or trauma surgeons or so on. But it is very common practice in India, particularly in casualty and emergency services, for doctors to be asked to do double duty. That is 8 and 8, 16 hours a day, they would be asked to do. They may not get their day off when somebody is absent. And in one analysis, the average number of hours that the doctors worked, resident doctors worked, was 88 hours per week. This is the kind of information that I got from the Indian literature, because for myself, burnout is a new term and a new era. I'll stop with this.
Yeah, so that's really shocking and surprising. Like the Indian data is also showing. Like I really appreciate that you really research and look for the Indian data. And Indian data also says that 42% is the burnout rate. That's really shocking. I was under the impression that probably we are immune because of the mindset which Professor Benjamin said, but that's not the fact. Probably we have more burnout rate than the USA. Now, I would like to ask Professor Goldberg about what is your experience about, like, is it more common in surgeons, or it is more common in physicians, or it's related to those who are doing emergency duty, odd hours duty, they are vulnerable to the burnout, or it's something else?
So thank you for inviting me and allow me to comment. The phenomena of burnout is not new. It was described in detail in 1970 by Christina Matlock, not even in doctors, and said that it was due to a chronic mismatch between people and their work environment. A mismatch of workload, a mismatch of expectations, a mismatch of values, that I, as a worker, have different values in my organization. And that created this situation that Cordelia described of being depleted, emotionally depleted. It's only recently that the questions have been posed to physicians. So we are not inventing this phenomena. It's been in the social service industries and teachers and others. And what we know is that it is this mismatch between the organization. It's not a sign that we have any weakness. It is just that we need to work in a supportive, non-toxic environment. And then when we ask caregivers, whether they are doctors or nurses, use any definition you want for this feeling, burnout, we then discover about 40% of physicians report it, about 50% of nurses, and up to 75% of residents and medical students. And so there is this milieu, and it is described now as burnout, or as we'll see as the conversation continues, some other words other than burnout. But this exists. It exists in us and it exists in our teams. I just want to take one moment to comment that I disagree passionately that burnout becomes a medical diagnosis. It is not a medical diagnosis. What's sick is the environment, not those of us who are practicing in that environment. It is the environment that needs to be treated. And for us, working in that environment leads to burnout, depression, suicidal ideation. Then we become the patients, but before it's the toxicity. And very quickly, the report that women have more, I don't think it's true. It's that women are more honest, especially about their feelings. And so they are more willing to say it. And with that, I'll turn it back to you.
Right. Now, like say, in India, we have two type of practice. The one is institute-based practice or a hospital-based practice. And the second is a private practice, means like the surgeon has his own small setup. So do you think that there will be any major difference in the group practice versus the solo practice? Jennifer, what do you think about that?
So, yes, to me, to piggyback on what Michael just shared, I agree that this is, I'm passionate that this is an issue for the environment and for the system and not for the individual. I believe that we have come to a spot where we are in danger of blaming the individual and going, when we talk about things like resilience, we are blaming the patient, the individual. So to me, the difference in practice setting, I believe, does have an impact. And I am saying this without data, and I am aware that I'm speaking to surgeons without data, so I apologize. However, I will share, going back to the origin of where this comes from, this mismatch of values. So as one has control of their environment, there is perhaps a better likelihood of being able to protect the individual. In the US, it doesn't matter if you are in private practice or you are in academics or you are an employed physician, the control and autonomy of healthcare in 2020 is poor. And so perhaps the private practitioner has a bit more ability to match their values with that of their environment on a micro level, but I don't think it's still possible on a macro level for us. I also want to go off script to respond to the bit about women and the higher reporting rates. I do agree with the honesty, perhaps, or maybe the transparency. But there's also a link that we understand between burnout, and you'll hear in a little while, I don't call it burnout anymore, I call it moral injury. So I'll discuss that in a little bit. But there's a link between these issues and the workplace harassment, bullying, and microaggressions. And I am standing on data with that. And I'm standing on data that we have not yet published from my own organization. But we understand that in a huge multi-thousand group of specialists in the perioperative space, so surgeons and anesthesiologists, as microaggressions, bullying, and harassment increase, so does burnout. And those three things increase for women and for underrepresented minorities, and the most for women who are underrepresented minorities. So those are my thoughts on that.
Okay, coming to the same question, Benjamin, you have probably worked all throughout your career in the institute, but many of your students have worked in a private practice. So
definitely there's a difference. And I'll take the example of somebody who's fairly fresh in the career, maybe a couple of years down the line. If you're working in an academic institution, you've got the backup of someone senior to you. So you can fall back on them when you're in a difficult spot. That is not available for the people who are working on their own. So there's a tremendous amount of stress on those who are doing it on their own. On the other hand, the issue of bullying doesn't apply because there's nobody to bully you except maybe your wife or somebody, right? So, okay, so bullying is much less because you're on your own, but you're faced with a lot more stress because you've got to cope with all the complications, the financial aspects, the problems that you face, hostile responses from a patient whose parents who got suboptimal outcome or whatever. So the stress there is much more, I think, when you're on your own.
okay. So what you said is absolutely right, that there are different scenarios for both groups. But first of all, to understand this situation, or before we think of anything for prevention, let us understand what actually causes this problem. So for any treatment, any preventive strategy, we need to find out a cause or causes what are responsible for this. So I now ask Cordelia, can you tell us about what do you think, what are the factors which are responsible for this problem?
Yes, I will do my best. The way I think about some of the factors, I think some are non-modifiable and some are modifiable. And so obviously when we start to think about strategies to make change, we're going to focus on the non-modifiable ones. The modifiable ones. Although I'm going to hit a point we just heard a couple times. But so let's start with the non-modifiable ones. So those are maybe individual factors, things like gender or age. Because again, when we looked at our data from POSNA, we saw that 57% of women reported burnout versus 30% of men. And that was a statistically significant difference. And so I do agree with Dr. Goldberg that women are in general better symptom reporters. I think this is why we're still trying to understand the true rates of concussion, for example, when we look in the pediatric sports world, and whether there's a true gender disparity there, or is it more about symptom reporting. But that said, women in the U.S. at least, I will speak to my experience, have unique challenges that some of our male counterparts simply do not. So, for example, only 6% of women in the AAOS, only 6% of members of AAOS are women. We know that there's this sort of magical 30% tipping point for any group to really feel like they're on solid footing within that group. And so I think some of it, sometimes feeling like a little bit of an outsider can contribute to burnout. We also know that women are way more likely to shoulder an increased burden at home. So in terms of of who's doing the dishes and the laundry and a lot of the caregiving at home, that seems to be still discrepant between the genders in the US. And then, I'll cite you just a personal anecdote in terms of inequitable pay. So I have a friend who is also a sports surgeon. She is she's a professor, I think a full professor. Her husband is one level below her. They were both asked recently by one of our companies to be a consultant, and they offered her way less money, even though she's had way more publications and presumably it should at least earn the same, if not more. And so I think, so I actually do think there is some real difference in terms of the percentage of burnout experienced as a function of gender. Then I was going to speak a little bit to then some of the modifiable factors. So these are the workplace factors. Some of them maybe are the tangibles, like structural things. So again, in the US, that's things like, do you get paid to take call? Many of us do not. I don't. I had a job where I took call 11 nights a month, and that was just sort of my life. And I guess unlike some of you, I didn't really like to accept it. Whether or not, if you do take call, you have access to a room the next day where you can get it, all the work done that you need to get done in a reasonable fashion. One of the biggest changes, I think, over the last 10 to 15 years has been the rollout of our electronic medical records. This is, there's a wealth of data that tell us that this has just phenomenally increased the administrative burden on all physicians, not just orthopedic surgeons. And then some of us have better access to things like scribes or advanced practice practitioners who can be a support and sort of fill in those gaps so that the burden just doesn't lay fully on us, and some of us don't. And so those are structural workplace factors. And then I was going to speak to what Jennifer just said, which is actually the culture of orthopedic surgery. And this is not just in the US. There have been some of this work actually started with the Royal Australasian College of Surgeons, who not specifically orthopedists, but who basically sort of looked inwards and found that their culture really not just tolerated, but almost taught and promoted harassment and bullying and discrimination. And so, and same thing in England, and same thing as we are finding in the US. And so a negative workplace culture in which you are experiencing discrimination and harassment and bullying, we know from work that we have also done and not quite yet published, which is why I was smiling before, because that's on my to-do list, is significantly associated with burnout. And so, and just like some of those structural workplace related factors may be modified, I think we can work together also to change and modify our culture to one that is more supportive. And so, those are my initial thoughts on, causes of burnout and sort of how to think about them. But I'd welcome anybody else to help me flesh that out.
Okay, let's have the opinion of Professor Sriram. Sir, what do you think about, from your vast experience, what are the factors, particularly when looking for the modifiable factors, which are responsible for burnout?
Getting a cue from the previous speaker, I'll just make a comment that out of all the causes for the burnout, most of them are unmodifiable in our country. I'll put that as the most important thing, because you see, in India, there is one doctor for 11,000 people population, as against the ideal, which is 1 in 1,000. Let's not go that far, but 1 in 11,000 puts an enormous workload on the doctor. And if you are working in a public institution like a government hospital or a public sector hospital, you would be overwhelmed with the crowd on which you don't have any control. And you are yet obliged to see and treat everybody without a complaint, with a VIP walking in or a politician walking in between. So that is an unmodifiable factor. And secondly, the hospital infrastructure in many parts of the country, except of course some excellent centers are there in India, and many of them offer very good infrastructure, but it's a vast country with variable levels of healthcare and infrastructure. I will talk for my state in Tamil Nadu, which is well developed as far as the infrastructure is concerned, even in a primary health center. But having traveled all over India, I cannot say the same thing of many other states in the country. So a poor infrastructure, lack of facilities is a very important factor, which is again unmodifiable as far as the doctor is concerned. Then every other day, alternate day, we see an item in the newspaper where for a patient's condition which has not improved or he has died, there has been a physical violence against the doctor or the institution, vandalization. That fear is always there. If you are in an institution, you are better protected by security. Nothing much happens. But if you are an individual private practitioner, the risk is always there. So the ideal thing would be like a person like me. We don't run a nursing home. We attach ourselves to corporate hospitals which have got all the facilities, and we go as visiting consultants. That is a third type of a doctor in this country. So these are the causes here. Then in our major institutions, government institutions or large corporate hospitals, we have no say in the administration or methods to improve the working condition in the hospital at all. There's absolute lack of autonomy. We can express our opinion, but we may not get what we want. For my own personal experience, I can tell you that I struggled for nearly 4 years to build an additional accident block in the hospital where I worked because I felt the need for it. And it took 7 years to complete the project. And by the time it was completed, I had lost interest in the whole project. You see, you can call it a burnout because I worked so hard for it for 4 years. And when it was actually completed, I did not find a sense of exhilaration. Of course, there are other causes of burnout which is modifiable. For example, the doctor has to be physically and mentally fit. And so he has to engage himself in some exercise, physical activities, hobbies. And of course, he needs a good work, good home life. His spouse must be accommodating. She must be understanding. And he must also learn not to carry his anxieties to the house and give a negative feeling at home. He has to make the life of his spouse happy and his children happy. So he has a responsibility towards that. And therefore, that is one factor which is modifiable. Of course, the greatest problem we have is we are not rewarded enough, but that is an individual perception. For in my days, in the days of socialism in our country, our income was extremely low financially compared to today. But I never felt a sense of dissatisfaction for earning less than many of my friends who were in other fields like engineering and science and so on. But it didn't affect me at all because I was earning less. But in today's world, a less financial reward means disappointment. And then the greatest problem is, irrespective of the kind of work you do, you don't get any recognition. Your promotions depend only on your seniority. Your own student for the post-graduation, he may be senior to you in service. He will get promoted on top of you. These are all factors which are not modifiable at all. So as Professor Benjamin said, accept your fate, endure what you cannot cure. Because many of us are in a position where the avenues for alternate employment are not open. You may be around the age of 45 or 50 and a very difficult stage to leave the service because you are not entitled for full pension benefits. Nobody wants to take you in a corporate hospital at that stage to start new all again. So there are many, many barriers and workplace problems which are responsible for maybe the burnout. We are belonging to the older generation. We studied for nothing. We didn't spend any money on our education. Our fees was very low. Exam fees were low. So we had practically free medical education. And therefore, we didn't feel the need for extra money. And we did not aspire to show off with huge cars and big palatial bungalows. We were satisfied with what we got. So this I would list as some important causes of burnout in India in today's life.
Okay, sir. Thank you very much for that. Now, before we move on, we would like to understand the burnout itself. Like in the beginning, I think Michael used a few terminology like depersonalization, emotional exhaustion, or the lack of accomplishment. So basically, Jennifer, can you explain what are the symptoms? Like these are the things which we say, but how actually they are manifested in the doctors?
Yes. So to me, when I first learned about burnout, I very quickly said, I have zero understanding of the difference between burnout and depression. So to me, as we start to talk about the symptoms of burnout, they are so incredibly similar. So the depersonalization, the emotional exhaustion, and quite frankly, and I know I'm sounding very American, anger. Anger. And what we do with that anger when it gets internalized becomes all of the depressive symptoms as well. I am taking a moment to breathe as I am hearing Dr. Sriram discuss the lack of options to change. And I am understanding right now the great privilege that we have in the US to be able to pick ourselves up and move when we are completely dissatisfied with our lot, with our organization. As we mature in our careers, the opportunities expand as opposed to retract. And that may be something I've taken for granted until this moment. So I thank you for sharing that. And I move toward the next term that I am going to share, which is moral injury. And I feel that I will read you the actual definition, and I do apologize, but I want to read it to get it absolutely correct. Moral injury refers to an injury to an individual's moral conscience and values resulting from an act of perceived moral transgression, which produces profound emotional guilt and shame, and in some cases, a sense of betrayal, anger, and profound moral disorientation. This is a term that historically was used to describe what people in the military went through. Acts that they had to commit that were not in line with their values, and the profound post-traumatic stress disorder continuum. And then in the US, physicians began to adopt this because of this inability, this perceived mismatch, to go back to Michael Goldberg's discussion of what our values may be and what we can provide for our patients, because the environment may not support what we know they need. The moral injury continuum, there's other words: moral outrage, moral apathy. I had the wonderful fortune to spend an hour a few weeks ago with Roshi Joan Halifax, who is a world-renowned Zen Buddhist priest. And she has, I recommend listening to her TED Talks. Our podcast that we did with her really honed in on this. And at risk of going off script yet again, I will bring up one more term that she taught me, which is pathologic altruism. So altruism is something that we rely upon as our antidote to all of these things. And Dr. Benjamin, I will admit that I covet your reaction to this lot. I too have faith. I'm a semi-observant Jew, but I have not gotten to the point where I can accept that altruism, the altruism to the point that the system is asking me to behave is in sync with what is appropriate and available as one individual. So this pathological altruism is very much in play for physicians when we are going above and beyond potentially, and sometimes it actually harms our patients, that we're trying so hard to please them or do what is right for them that we over test them and we over refer them and we over diagnose them. So I have taken up too much time on this, but those are some terms that I will put out there for people's interest.
Okay, so now let's come to the prevention. We realize that there are a lot of reasons. Some are modifiable, some are not. So let's talk something or understand about how to prevent it. So basically, I would ask Professor Benjamin, what are your suggestions for preventing this? Like what you said is changing the mindset or the mindset which you have, but it's very difficult to adopt that mindset. So what are your suggestions?
First of all, if the question is asked, can it be prevented? The answer in one word is yes.
Okay, good. So
how can you prevent it? Things that cannot be changed. We need to have the wisdom to accept what we cannot change. And what we can change, we should try to change. Now, having said that, if the institution, for example, in my institution, the patients had to pay for treatment. And if the patient couldn't pay that amount of money, the option is either send them away saying that we can't treat you, or ask the institution to subsidize their treatment. Now, this institution made it clear that they can't keep doing that always whenever a poor patient came. So you're left now with this choice, either treat them or send them away. How are you going to treat them? So you take a call, and if the call is, you will find the resources, so be it. You understand? So similarly, you find issues that you can try to deal with and deal with it where it's possible. And the bottom line is, the sooner you learn to be content with what you have, the less likely you are to have burnout. Contentment, to my mind, is the cure, prevention, absolute prevention for a burnout. Contentment of your lot. Change what you can. Have the wisdom to know the difference between what can be changed, what cannot be changed. And I would mention that both Dr. Michael Goldberg and Dr. Sriram have lived wonderful lives. And at this stage, they're still active. They're not burnt out. So they have been through difficult situations and gone around them, circumvented them, overcome them, and they're not burnt out. They're a wonderful flame still burning, right? Okay, so I believe
yes.
that we can.
Yeah, Michael, what do you think, like from your last 20, 30 years of experience, can it be prevented?
Yes, I thank you for the nice comments and about still enjoying practice. There are a couple of things, though, that I want to address what's been said. If it's modifiable or unmodifiable, most studies show that individual factors account for about 20% and system factors account for about 80%. And so we may enjoy, okay, I'm going to do the 20% and find my happiness and contentment and stand by and say there's nothing we can do about it. However, we know that bad systems bring out the worst in people. They bring out the worst in doctors, and they bring out the worst in their patients, as some of the examples are given of it, violence or other things. And so the question is, can we accept that 80% of it is unmodifiable? Maybe we need to start thinking differently about how we could work in the system, both in the United States and in India. Industry in India has modified greatly over the years to keep up. They've made many changes so that they are centers in pharmacy, they are centers in electronics and computers. Maybe we need to speak about the business aspects of having a work environment that is modifiable and better and not leading to the burnout. So focusing a bit on the business case or on the political case is something we need to think about. Otherwise, yes, things that improve me individually, they have been looked at, they have been studied. Colin West from Mayo Clinic did a meta-analysis, and he did show that meditation and mindfulness and small group discussions and stress management are all helpful. They'll give us the path to some sense of accomplishment and feeling good. But I think at the end of the day, it's going to be a loss of physicians if we don't address the systemic situation, and a loss of nurses and a loss of doctors. And perhaps we ought to get together to think about how we can address the system. So that may have not been a specific question, but I don't want to leave here with a sense of hopelessness that it's not changeable. What kept me active and what keeps me healthy and engaged is being hopeful. And we have to work on solving that.
Okay, Cordelia, I would like to ask you a very specific question. Suppose a colleague who has recently joined a practice comes to you with a specific question that you are the expert of burnout. What are your suggestions for prevention of burnout in my career? So what are your tips to that young doctor?
Well, I think first is arming yourself with information, right? Like you need to know, so what are the causes, just as we're outlining here? And then I think, I would tell that person which of those are applicable to you, right? So if one of your causes is gender, and maybe that's a very purposeful restructuring of your home life, right? Or maybe it's, if you can afford it, hiring somebody to help offset that workload. If it's looking at a job that somebody is just joining, I think, to go back to sort of what Dr. Goldberg was saying, I think that, and POSNA is starting to do this, we're trying to basically get the data so that we can give it to our members, who can then go to, when they're signing a contract or renegotiating a contract, they can say, look, I know that if I don't get paid for call, and I have this much call burden or this much electronic medical record burden, that I'm going to be a higher risk for burnout. I'm going to be less effective and less productive, and that's going to be bad for your bottom line. And so knowing that those things may contribute to, ultimately what's bad for the business, unfortunately, of medicine, may in fact be tools that we can put in our bag to preemptively avoid burnout. I think those are two of the things. Actually, I'd like to make a comment also on, I'll say two other things and then I will be quiet. I think, to me, the main things are control, and so anything that you feel like that may be within your control, that I think is empowering. But I really love the comments about, if something really isn't in your control and you continue to bang your head against it, I think that is disheartening, and it leads to hopelessness. So recognizing what is in your control and then working, to change it in a purposeful way. But then I think this mismatch too. I think some of the situations that were described, I think if you have just so very many patients you feel burnout by treating all of them. I think that's exhaustion, which may be different from, I think in the US, for example, again, our electronic medical record, that's just busy work. And so I think if you don't feel like your work is valuable, I think that also really contributes to this sensation of depersonalizing and wanting to pull away, because you're not helping anybody by, signing another chart. And the other thing, that 20% with because I think the first thing a lot of places will do when they have like a wellness symposium is say, like, again, change yourself, increase your resilience, go practice mindfulness. And it's sort of like a list of things to read and do that at the end of the day just adds to the burden. And so I think we have to be able to figure out a way to empower people without overburdening them as well.
Yeah, thank you. Professor Sriram, what do you think in India, the strategies which Cordelia said, they are not really applicable. So what are your tips what will be your tips to the young orthopedic surgeon coming to you and asking that what should he do or she do for prevention of the burnout?
Yeah, you see, the young orthopedic surgeon will be burning with enthusiasm to do his work. So whoever is the head or the unit chief for him should not overburden that enthusiastic doctor to do a lot of work. That's very important. The unit head must be able to find out who is the person in his team who is capable of doing the work. Certain amount of man management is required. He must know, the unit head must know how to delegate the work so that he himself is not overburdened. He must identify which Mr. X or Y or Z, who's the senior assistant professor, can do a job correctly so that he doesn't have to go into the picture. That is very, very important. So job analysis, delegation, and limiting the working hours. A young person will be keen to learn, get the experience, and do the work well. So he has to be given the opportunity to do that in his own time, and do it well, and not discourage him when he makes a mistake. That's very, very important, not to insult him openly in the ward. That is a very important factor. The other important factor, previous speaker referred to the electronic medical records, to which we are also exposed for the last 8 or 9 years. As an old-time doctor, I feel that the direct eye contact that I have with my patient is definitely reduced, because when I am talking to him and taking the history, I am typing at the same time. I am uncomfortable about it because I think that I have lost the eye contact with my patient. So very often I do the full consultation and then I do the typing, which is not possible in the crowd that we face here, even in a private setup. So that is a very serious handicap which we face now, because all of us don't get help to type the records, because no other type of record is available. It's a paperless hospital. So you are forced to do it. But you are not having the personal interaction to the great extent that you had a decade ago. That's what I feel as far as the practice is concerned. Of course, the more important thing is, you may be having a long day and a hard day at work, but I think we should not take to alcohol in a big way or go for substance abuse, because that will have a deleterious effect on your performance the next day, which will lead to a poor outcome for the patient. A lapse in your medical care, again, is a vicious cycle. So it's very important. As I mentioned earlier, exercise, physical activity, hobbies, listening to music, and all that is very important. I think these are the methods by which you can take to some preventing the burnout.
Okay, Jennifer, just your comments, like we have suggestions from USA, then you also saw the suggestions from India. What do you think? those suggestions can help the young surgeons to prevent burnout? Or
Yeah.
unless and until what Professor Benjamin said, that unless and until we change our mindset, we reduce our expectations. What do you think?
Two things that I would add as tools. One has just been mentioned. Dr. Sriram talked about eye contact with the patient. I think about the physician-patient sacred relationship is absolutely protective against burnout. That's why we went into medicine. So the more that I can connect with my patient and recognize that and be grateful for it, and make organizational changes to allow that connection, and also to connect with my peers and my colleagues. Tate Schoenfeld is a very famous US physician who has studied this, and that collegial connection in whatever way we can form is tool number 2 that I would suggest to that young surgeon starting out.
So one of the major problem which we have seen in the burnout is, like recently also on a WhatsApp, we saw that a young orthopedic surgeon, he did some surgeries for the congenital pseudoarthrosis of tibia, and there was on-table death. And ultimately, there was so much harassment from the family member that surgeon himself has to carry out suicide. So, Professor Benjamin, I would really like to ask, like, what will you suggest to the young doctors when such complications occur? Complications are always going to occur. Any surgeon who is operating, complications are going to occur. But how to face such situation?
First of all, one advice I have to young orthopedic surgeons is, when you're starting out on your own, take on only what is safe. Start small. It'll take time to build up a practice. It may take time to build up adequate revenue, but don't let that worry you. Start with something small. Unfortunately, what happened in that particular incident you're referring to, his wife was the anesthetist. The young boy had a cardiac problem, and other centers had declined surgery because of the cardiac problem. Now, this young man and his wife were in a small nursing home together without any support. And they ran into complications and he unfortunately died. So this is a typical example where I thought it's an error of judgment that they shouldn't have taken on such a case. So the first thing to remember is, start small, do things that you're very confident of, and slowly build up a practice. You build up your confidence, you build up your reputation, and then over a period of time, things fall into place. With regard to dealing with patients, it's a universal problem. The more you talk to them and interact with them and you plainly tell them the truth, the less likely you are to run into problems. And when you have a disaster like a death on the table, it is extremely difficult to reconcile. But we may encounter this. If we do, we have to really be careful about de-stressing ourselves, maybe take a couple of days off, probably if necessary take counseling and take some advice from some seniors, because that can really give trouble. And I think this type of an event shouldn't happen, so it should be more prevented.
Yeah, that's really good practical suggestions.
The only other thing that I would say is, I think it was Jennifer who mentioned that if you are asked to do things against your basic principles in an institution. For example, if you believe that genuinely you shouldn't be operating on a child. For example, if you thought it was your own child, you wouldn't operate. But you're under pressure to get a little money. They say, why don't you operate? Don't treat it conservatively. If if you have to violate your basic principles, then you should leave. If it's not compatible, your honest beliefs are at variance with that of the institution, then there's really no place to work there. So these are two things that I would advise youngsters.
Yes, that's really very useful suggestions for everyone, not youngsters, everyone. that try to understand your limitations and don't try to go beyond that. Jennifer, is it really a problem in USA, such complications? Does it really affect to your practice to great extent, or is it really a moral injury to the surgeon?
Yeah, the term that we use in my organization is, and in many here, is second victim. And so when we, it's much like the two arrow story that we hear from the Buddha, actually, in that the first arrow or the first victim is the patient that withstood the complication, and then the second are the clinicians that are part of the team, it's a huge issue. I think Dr. Benjamin just gave some great advice about it. We have a team of coaches that are physician peers standing by to sort of guide people real time. And it is something that, as you said, if you operate, you will have complications. If you have complications, if you're a person with a beating heart, you will have stress over it. And being able to connect with your peers about this stress is imperative, and recognizing it is imperative.
Okay, so this is one of the very good term, like the second victim, which is really a true thing. Like the one complication has already occurred, but the second complication is already in the process, and definitely we can take some measures to prevent it. Okay, now coming to the changing the gears, and now we are coming to a completely new issue. Michael, you are really fond of, or you are propagating the compassionate care. Like you are at present with the SWAT Center, which is promoting the compassionate care. So what do you think? Does it really help to reduce the burnout if we really involve with the patient? Do you think that that is one of the important prevention or like the strategy to prevent burnout?
Yes. And I'll say
explain. Yeah, can you explain to it why?
So I'd like to give a 1-minute course on neuroscience that will talk about compassionate care, and at the same time will bring together a lot of what we've been saying all along. First, what is compassion? And compassion is the feeling that arises when you see someone suffering, but it's coupled with the desire to relieve that suffering. There are two parts, the feeling and the desire to relieve. And I would argue that we are hardwired for compassion. We are hardwired for compassion. And a number of neuroscientists, Singer, Clemenke, have studied compassion using functional MRI. Functional MRI, just like it can disclose movement, can also disclose emotions. And it shows that when we feel this suffering, this empathetic concern about a patient, it lights up in our pain center. It's like one neuron over from a pain center. So we are really experiencing their pain. But when we do something about it, when we relieve that suffering, that lights up on functional MRI in our reward center. And so what do we have? We have a circumstance, if we are practicing compassion, we are feeling the empathy and we're feeling the pain and we are relieving it. And I would argue that burnout and many of the things we are experiencing occurs when you know what the patient needs. Your pain center lights up, but you're unable to deliver it. So you don't get the reward side. And day in, day out of only being able to feel their pain, but not being able to feel the reward of giving the patient and the family what they need. A good example is what you spoke about, seeing the patient, this connection to the patient. That's what the patient needs. You're unable to do it. Burnout is when you're unable to deliver it. And that's side of it. And that is what is taking its toll and actually leading to the burnout. You don't have enough time. You don't have the right tool. You don't have the patient doesn't have insurance. All the things that you can't do to deliver. What is it from a patient and physician point of view? Think about it. What was your last encounter with the patient compassionate? Did you feel what they needed and relieve it? That is the doctors who have burnout don't feel inefficient. They feel ineffective that they're not able to do this. Unfortunately, the system in the United States that's been studied shows that less than 50% of patients feel that their last encounter with the healthcare system was compassionate. And if you ask caregivers, are they delivering compassionate care? Are they delivering it? Only about half the doctors and less than 40% of the nurses say that they're able to deliver compassionate care. So that as a background of what it is, and I think it's foundational to this conversation. And Professor Sriram and Jennifer and Cordelia and Ben, they all gave examples of this if we put it into this neuroscience hardwire perspective.
Yes, Professor. Professor Sriram, what do you think about compassionate care? Like he explained it very well with the functional MRI. Now, what are your views about that?
Well, I think as far as a doctor is concerned, compassionate care is a necessity in his profession. It is not a luxury or something extra that he needs to have as far as giving care to the patient is concerned. I think we are all brought up with the philosophy of compassion, whether we are Hindus or Christians or Jains or any other religion. When you are taught by your parents and your elders at home, compassion to all living beings is a central theme in the philosophy of every religion, whether it is Hinduism, Christianity, etc., etc. So I think it is inbuilt in the human nature to give compassion. Of course, as Dr. Goldberg has nicely explained, it is not enough to be sympathetic, like rendering condolences when a person dies. One has to have a positive action to remedy the suffering of the patient. I think that is very important. And I think in a hospital setup or a private setup, a very good understanding bridge nurse can be a bridge between the doctor and the patient. Because as a visiting doctor, you may not be able to spend a lot of time with the relatives to give compassionate care. But an understanding nurse who understands the problem with the patient and the person looking after the patient can be a good bridge between the doctor and the patient. I think that is what is very important. Of course, it has to have professionalism also. Particularly, you have a patient with advanced malignancy, with pulmonary secondaries, and they're going to die. But that doesn't mean we can stop seeing the patient. We have to go, smile, talk words of encouragement, but be honest with the relative who is going to lose her child. I think all these are examples of compassionate care. But I think we have the greatest satisfaction. For example, for me, if I operate free in a government hospital or any institution, even in my own institution, if the services are free, and I have a patient with a tuberculosis of the spine with paraplegia, I operate and that patient gets up and walks, then I have the greatest level of satisfaction. Even though I might not have got any financial reward, but it gives me a great sense of satisfaction. The man who's been bedridden due to paraplegia has got up and walked. I think I'll stop with that.
Okay. Yes, Professor Benjamin, how do you look at compassionate care in the overall problem? Like, is it a solution to burnout or it is just a feeling good? How do you look at burnout in the overall situation?
I believe that compassionate care is integral to what we should be doing. I have absolutely no doubt about it. I'm also quite sure that if you can offer compassionate care, the chance of burnout is going to be much less than it would be otherwise. And the hindrances or the obstacles for offering the care is something which we need to deal with. And that, again, it falls into things that can be achieved and things that can't. And what cannot be changed, there's very little you can do about it. But the effort must be there to change as much as we can change. And I believe that, yes, compassionate care is what we need to offer. It's a lovely term, something that we haven't used in the past, but I think we understand the emotion behind it.
Okay, then Cordelia, I would like to ask, like, group practice. Whenever like we are in a group practice, we have to connect with our colleagues. And when we are dealing with people, that can be also a source of problem. And that can also lead to dissatisfaction with our profession. So what are your tips for preventing what we say, like, or maintaining a good relation with our colleagues?
Well, let me think a second, because I was ready to answer. How does working in a group practice increase vulnerability for burnout? And what I was going to say to that, actually, because it harkened back to some of the other things that we've talked about, and then I will answer your question. But I actually think working in a group practice may be very protective against burnout, right? I think for the example of a young surgeon coming into practice and needing those mentors, or if you have a bad situation and you need to have that guidance and people to whom you can go for advice that you trust, and because you're part of a collaborative effort. So I think, in many ways, being in a group practice actually could mitigate any effects of burnout. But then the flip side of that is, so when instead could it increase vulnerability for burnout? And I think it is, again, like some of these systems issues. So the example that we heard earlier about, what if you're working in a group practice and decisions are being made based on finances that are against your sort of moral code, right? You get told to do a surgery, or you're encouraged to do a surgery that you don't really feel is needed, and that the risks may not outweigh any perceived benefits. Or again, and so what if your group practice happens to be one in which the culture does really perpetuate discrimination or bullying and harassment, and so simply being in that work environment may work against you? Or a different kind of work culture, which glorifies working your fingers to the bone, right? Work must be the most important thing, the only thing, to the exclusion of all the other things that we said may help prevent burnout, like hobbies or spending time with your family, or all these other things that make us whole people. And it's those whole people that ultimately are able to take the best care of our patients. And so I think again, in terms of just advice for anybody that is thinking about, well, how can I personally prevent burnout for myself or my institution? I think it's understanding the contributing factors, understanding the ones that you can change, and then working ideally not just you against the world, but in a collaborative effort to do so, and ideally in a data-driven way.
Okay, yeah, thank you. I think, Sandeep, do we have questions?
Yes, there is one question from Professor Sriram. Professor Sriram is asking, he has asked a question that one orthopedic surgeon who was of 25 years standing was suddenly suspended from his government service on the whim of a politician. He appealed for a formal inquiry and was eventually exonerated. but the process took about 2 years. In the meantime, he took up the job of a soccer coach. And even when he was restored, he did not return to orthopedics and continued as a soccer coach. So what would you call this condition, and what do you make of this?
Yes, Professor Benjamin, like you are smiling. So like, what are your comments?
I think he
was a state football player.
Yeah.
So, you know, he was always in touch with soccer, and he thought that was the best avenue for him to take up coaching.
I think so too.
I would say.
What label would you give for this condition? What's the label, Dr. Goldberg?
I think that he was practicing compassionate care outside of a hospital setting. He recognized the needs in the students, the amateurs, and he was able to relieve that by his coaching and having them be successful. So in his hard wiring system, he was doing the work that brought him satisfaction and reward. It's sad that the process didn't allow him to do the same thing in a hospital setting, because the disease of the system drove him away. 2 years to resolve that problem. So,
yes, Benjamin, yeah.
No. I was reminded about the Freudian philosophy that if you want to take out your anger, kick a ball. So I was wondering whether he was getting even with the politician by playing football, imagining the face of the politician each time the ball came to him. I don't know whether that's therapeutic.
No, but it's really, yeah, Cordelia, please.
No, I was just going to speak to that. I mean, I think, and Michael, I'd be interested to hear your opinion on this too. I think there must be some level of heartbreak as well, right? I mean, I think, how can you not feel forsaken by the profession that you've given, you've donated your life to? And I think, and so maybe it really is making a lemonade from lemons by finding something that you can be equally passionate about and enjoy. But I also think there's some injury there.
I agree. And I think he is grieving, and there has been injury. When we look at how do we build a compassionate workplace in the hospital, we do so at 3 levels. 1, how do you develop self-compassion? How do you find self-forgiveness? And secondly, how do you build compassion in your teams? How do you nourish compassion in one another? Second victim, other conferences, safe places to talk about it. And third, how do you get an organization to implement systems that allow you to practice compassionate care? And so it is, all of those things are needed. And I'm sure that there may have been failures in both self-compassion, the team compassion, and organization. And if I may say one other thing for thinking, and maybe it would stimulate conversation. When you did your opening principles, I agreed with everything except patient-centered care. I think it has to be human-centered care, because the patients don't practice alone. They don't do their own DDH reduction. There's always a clinician with them. And that the experience of the clinician drives the experience of the patient. And unless we as physicians and surgeons are having a good experience and are part of that caregiving, our patients won't. So I would like us all to move forward, beginning to use the term human-centered care, which better describes what the future teams will be like and how compassion would thrive.
Yes, so now we are coming to the end of the webinar. It's a huge topic. I request all the audience members to read a supplement of Journal of Pediatric Orthopedic of July 2020, which is a whole issue is on burnout, and everything what we discussed today is covered in that supplement. So those who are interested to read more, please read that supplement. And there are 2 more articles published again in Journal of Pediatric Orthopedics. So there is a lot of literature on that. So with that, I hand over to our secretary, Dr. Sandeep Patwardhan, for vote of thanks and summarizing the session. Over to you, Sandeep.
Thank you very much, Dhiren bhai. So it's been a real pleasure and an illuminating session on a little different topic compared to the webinars that we usually do. And I must thank and compliment Dr. Goldberg, Dr. Jennifer Wooze, our seniors, Dr. Benjamin Joseph, Dr. Sriram, and Dr. Cordelia for participating in this wonderful webinar, and Dhiren bhai for wonderfully asking the relevant questions. Burnout is a real issue which is going to face the young orthopod as the competition and crowding of doctors increases, especially in the urban setups. Somewhere, compassionate care, what Dr. Goldberg has just highlighted, which I thought was a given, has to be now reinvented and relearned. I feel that we are joining medicine in India too soon. We are forced into a professional line of MBBS or choosing a specialty very early in life before we are mature, compared to the European or American systems where probably 3 years you spend doing a basic degree and then you get into medicine. In fact, I was speaking to Professor Holz from Germany when I visited him, and he said 1 year of psychology and 1 year of philosophy must be mandatory before getting into medicine. Unless you know what drives your satisfaction, if you get into medicine, there is a very high chance that you will be disgruntled and burn out soon because you're in the wrong place. I think that's very, very relevant. And thank you for bringing out various aspects of burnout, compassionate care, and how youngsters can take care of themselves, including group practice, having mentors, philosophers, and a shoulder to lean on as well as try on. Thank you very much, gentlemen, and have a very good night and stay safe from COVID.
Gentlewoman also.
It's neutral, everybody.
Okay. Okay, thank you very much. Thank you. Thank you.
Thank you.
Bye-bye, Michael.
Okay, bye-bye. Yeah.
Bye-bye. Stay in touch and stay well.
Sriram, lovely
Yeah.
hearing.
Thank you, ladies.
Yeah.
Thank you.
Thank you, Jennifer. Thank you, Cordelia. Yeah.
Stay safe.
Yeah. Stay safe. Yeah.